Okay, picture this. The incredible power of seeing inside the human body, not through surgery or cutting, but using something as simple as sound waves. How do we gain crucial insights, peek into hidden processes, and detect potential issues within, all with just a little wand and a screen?
It's really quite amazing when you stop and think about it.
It is. It's about understanding what's happening deep inside, unlocking the secrets held within our own anatomy. And when it comes to women's health, especially the pelvic organs, this technology is nothing short of revolutionary.
Absolutely essential, yes.
Understanding this diagnostic tool doesn't just demystify medical processes. It truly empowers our curiosity about our own bodies, offering the comfort and relief that often comes with knowing. It gives you a window into what's happening beneath the surface. Welcome to the deep dive. Okay, we're going to plunge into a fascinating and fundamental area of medical diagnostics, basic gynecological ultrasound.
Sounds good, a really core topic.
We've taken a key stack of source materials on this topic, primarily a core presentation that walks through the essentials. Our mission in this deep dive is to extract the most important knowledge and insights from these documents, breaking down the technical details into clear, understandable concepts so you can gain a solid, well-informed grasp of basic gyne ultrasound.
Looking forward to unpacking it.
Before we jump into the waves, we want to express our sincere gratitude for the educational support that has made this deep dive possible. A special thank you goes out to London Heartbeat's Z Academy UK.
Great resources there.
They are a fantastic resource for expanding your knowledge, offering an extensive range of over 150 popular courses across numerous fields. If you're eager to learn more about medical topics or explore other areas that pique your interest, we highly encourage you to explore their offerings.
Definitely worth checking out.
And while you're at it, make sure you connect with London Heartbeat's Academy on social media. You can find them on Facebook, Instagram, and YouTube. They provide free, regular updates, fascinating insights, and subscribing to their channels is a great way to ensure you don't miss out on future amazing discussions and learning opportunities. Go check them out.
Good advice. Stay connected, stay informed.
All right, let's unpack this. Our journey begins with the title itself, presented on the very first page of our core source material, Basic Gyne Ultrasound. This immediately tells us our focus is on the fundamentals of using ultrasound technology, specifically within the field of gynecology, the study of the female reproductive system.
Sets the scene perfectly. It's the foundational layer.
It signals that this isn't about highly specialized techniques, but the core knowledge everyone working in the field or anyone interested really needs to grasp first.
That's right. The title sets the stage, indicating that this presentation is designed as an introduction, focusing on the essential principles and appearances that someone new to this area or needing a solid review would need to understand. It's the 101.
Moving into the substance, the second page delves into the introduction and basic scope of gynecological ultrasound. It highlights that ultrasound, often abbreviated as USG, is a commonly used diagnostic imaging technique.
And right away, it makes a crucial point. What this page emphasizes, which is absolutely critical to grasp from the outset, is that USG is a diagnostic tool and not a replacement for a patient's full clinical picture.
Okay, so it's part of the puzzle, not the whole picture.
Exactly. It explicitly states that ultrasound should not replace taking a thorough patient history, performing a physical examination, or considering other relevant clinical information. You need the context.
So the scan result isn't the only thing that matters. You can't just look at the image in isolation.
Far from it. The source stresses the importance of clinical context. It specifically mentions needing information like the last menstrual period or LMP.
The LMP. Why is that so important?
Knowing where a woman is in her menstrual cycle is vital because, as we'll see later on, the normal appearance of the pelvic organs, particularly the uterine lining, changes significantly throughout the month.
Right, things look different depending on the time of the cycle.
Precisely. Without that piece of information, interpreting the scan findings can be very challenging or even misleading. What looks normal mid-cycle might look abnormal just after a period, and vice versa.
That makes perfect sense. You're using the ultrasound image to complement and confirm what you suspect based on the patient's story and symptoms and their cycle timing.
You've got it. It's about integrating all the information. The source also includes a point about the learning curve for mastering ultrasound. It mentions it involves a longer learning curve.
Meaning it takes time to get good at it.
Yes, it acknowledges that becoming proficient in performing and interpreting these scans accurately requires substantial training, dedicated practice, and experience. It's a skill that develops over time, requiring the ability to navigate anatomy, understand the physics, and recognize subtle variations in appearance. It's not just point and shoot.
Okay, so it's a skilled art as much as a science. What's the fundamental goal then, the primary objective of performing a basic gynecological ultrasound according to this source?
The page defines the fundamental goal very clearly, distinguishing normal findings from abnormal ones. At its core, the sonographer and the clinician reviewing the images are trying to answer the question, does this look like healthy, normal anatomy for this person's age and clinical situation, or are there features present that indicate a problem? Is it normal or is it not?
Normal versus abnormal. Simple goal, but probably complex in practice.
Yeah.
And how do they actually get those images? Does the source introduce the different ways of scanning?
Yes, it introduces the two primary scanning techniques used in gynecological ultrasound, the transabdominal scan, or TAS.
That's the one on the tummy, right?
That's the one, yeah. And the transvaginal scan, TVS. It also briefly touches on the classic question regarding TAS, the need for a full bladder, hinting that the requirement depends on the specific scan and the patient's condition. Sometimes you need it, sometimes you don't.
Why are there two different techniques? What's the basic difference in approach?
Well, the source doesn't go into the deep physics here, but TAS, being on the abdomen, is further away from the pelvic organs. A full bladder can help push the bowel gas out of the way and provide a sort of window to see through.
Okay. And TVS?
TVS uses a specialized probe inserted into the vagina. This gets you much, much closer to the uterus and ovaries.
So getting closer likely provides a better, more detailed picture of the pelvic organs themselves, like a close-up view.
Exactly. Generally speaking, TVS offers higher resolution images because you can use higher frequency sound waves which don't need to penetrate as far. We'll see later how the source hints at the preference for TVS for visualizing structures like the ovaries in detail.
Gotcha. What are the specific organs they are primarily focused on imaging in a basic scan?
The primary focus listed is on imaging the pelvic organs. The core purpose stated for a basic gynecological ultrasound is examining the normal anatomy of the uterus and ovaries.
The main players.
Right. And evaluating the changes they undergo throughout the menstrual cycle. This loops back to why knowing the LMP is so crucial. You need to understand those normal cyclical changes to identify what's truly abnormal.
Right, establishing the baseline and seeing how it fluctuates normally. But the scan is also about identifying problems. What common abnormal findings does this introductory page list?
The source lists several common pathologies that might be detected. These include structural abnormalities of the uterus, like fibroids and adenomyosis.
We hear those terms a lot.
Yes, and also ovarian issues such as ovarian cysts, endometriosis, or even more concerning conditions like cancers affecting the uterus or ovaries. It's a broad overview of the diagnostic scope.
Does it give us any preview of what these abnormalities might look like on the screen? Like a quick snapshot?
Yes. It provides a very brief introduction to the appearance of some of them, just hinting at the distinct features. For fibroids, it mentions they appear as well-defined masses inside the uterus.
Well-defined, like a clear lump.
Exactly, clear borders. It also notes they can have varying echogenicity.
Echogenicity. That's how bright or dark it looks.
Precisely. It refers to how strongly it reflects the sound waves. So fibroids can look brighter, darker, or a mix compared to the surrounding uterine muscle. But the key phrase here is well-defined masses.
Okay. What about adenomyosis? It used different language for that one, didn't it?
It did. For adenomyosis, it uses very different terms, describing a diffusely infiltrative, inhomogeneous appearance of the myometrium, the muscular wall of the uterus.
Diffusely infiltrative.
Yeah.
So spread out, not a neat lump.
Right. Instead of a clear lump, this suggests the abnormality is spread throughout the muscle, making it look patchy and less uniform. Inhomogeneous means not uniform in texture or appearance.
Diffusely infiltrative and inhomogeneous are quite a contrast to well-defined. That's a key difference right there.
Absolutely. It immediately signals that these two common conditions affect the uterus in fundamentally different ways, which is reflected in their ultrasound appearance.
And what about ovarian cysts?
For ovarian cysts, the source states that evaluation involves looking at their size, whether they persist over multiple menstrual cycles, and specific characteristics that might suggest malignancy, meaning cancer.
Okay, what kind of characteristics are worrying?
These worrying characteristics include things like irregular walls, the presence of ascites.
The cysts that's fluid in the abdomen.
Yes, free fluid in the belly cavity, or strong blood flow within the cyst detected by Doppler ultrasound.
So for cysts, it's not just, is there a cyst, But what does it look like internally? How big is it? Is it sticking around? And does it have any of these red flags?
Exactly. Those features help assess the likelihood of it being a simple benign cyst versus something more complex or potentially malignant. The vast majority are benign, but you have to look for the signs.
And there was a crucial clinical point mentioned about postmenopausal bleeding. That sounded really important.
Yes, this is a vital takeaway right from the introduction. The source states clearly that postmenopausal bleeding requires further histological evaluation.
Histological meaning a tissue sample, a biopsy.
Yes, exactly. This is extremely important because postmenopausal bleeding is a potential symptom of endometrial cancer. While ultrasound provides valuable information about the endometrium's appearance and thickness, the presence of bleeding after menopause automatically triggers the need for a tissue sample, histology, to definitively rule out cancer regardless of what the ultrasound shows alone.
Wow. So even if the ultrasound looks okay, the bleeding itself means you need that biopsy.
Correct. The clinical symptom drives the next step in that specific situation. It really emphasizes that ultrasound is a part of the diagnostic puzzle, but not always the final answer, especially in concerning clinical scenarios.
It guides the investigation, but doesn't replace other necessary steps.
Precisely. It guides the next steps in the investigation.
Okay, so we've been introduced to the basics, what ultrasound is used for in gynecology, the techniques, the general goal of normal versus abnormal, and a preview of some key appearances, plus the crucial importance of clinical context like LMP and symptoms. Now let's build on this foundation by diving deeper into the normal anatomy, following the structure of the presentation. Page 6 starts with the uterus.
Right. Page 6 focuses specifically on the normal uterus, providing key details about its shape and typical size. Knowing these dimensions is fundamental because any significant deviation, whether it's enlargement or changes in shape, can be the first sign of pathology.
So what are the average measurements given in the source for a typical uterus?
The source provides average dimensions for a non-gravid, so non-pregnant uterus. The length, measured from the top, the fundus, down to the cervix, is typically 7.5 to 8.0 centimeters.
Okay, about 8 centimeters long.
Roughly, yeah, that's the longest dimension, essentially how tall the uterus is.
And the depth? Front to back?
The depth is measured from front to back, the antero-posterior dimension, often called AP diameter. This average is given as 4.5 to 5.0 centimeters. This measurement helps assess the thickness of the uterine muscle wall and the overall anterior-posterior size.
So around 5 centimeters deep. What about the width, side to side?
The width, typically measured in a coronal view, looking at it face on, is 2.5 to 3.0 centimeters. So it's generally widest near the top or middle and narrower towards the cervix, sort of pear-shaped.
So roughly 7.5 to 8 centimeters long, 4.55 centimeters deep, and 2.53 centimeters wide. Knowing these specific numbers creates that baseline, doesn't it? If a uterus measures significantly larger in one or all dimensions, it immediately makes you think about conditions that increase uterine size, like the fibroids or adenomyosis we touched upon earlier.
Exactly. Establishing these normal parameters is the starting point for identifying maybe a bulky uterus or localized enlargement caused by masses. You need to know what's normal to spot the abnormal.
Right. Now, as we noted, the uterus isn't a static organ, especially in women of reproductive age. Its lining, the endometrium, goes through remarkable, predictable changes throughout the menstrual cycle. That brings us to pages 10 and 11, which detail these cyclical transformations.
Okay, page 10 introduces the concept of the menstrual cycle driving endometrial development. It emphasizes that the endometrium, the inner lining of the uterus, undergoes predictable cyclical changes in response to hormonal fluctuations, primarily estrogen and progesterone.
And this is all about getting ready for a potential pregnancy.
That's the biological purpose, yes. These changes prepare the uterus each month. And this page introduces a key measurement related to the endometrium.
The ET.
Yes, it defines endometrial thickness, or ET. This is a critical measurement in gynecological ultrasound. The source specifies that ET is measured as the double wall thickness.
Double wall, what does that mean exactly?
It means you measure across the uterine cavity, including both the anterior, the front layer of the endometrium, and the posterior, the back layer. You measure from the outer edge of the front layer to the outer edge of the back layer, capturing the total thickness of the lining filling the cavity.
So you include both layers together, not just one side.
Correct. Measuring the combined thickness is the standard way to get the ET, providing a consistent value for comparison across different scans and different people.
Okay, got it. Then page 11 shows us how this thickness and the appearance change throughout the cycle. This is where ultrasound provides a visual representation of those hormonal phases, right?
Exactly. It provides a breakdown of the ultrasound appearance and typical thickness ranges associated with the key phases. So right after menses, when the lining has been shed,
Start of the cycle.
yes, the endometrium is very thin. Its appearance is described as homogeneous, meaning uniform in texture, and the thickness is typically only 1 to 4 millimeter. There looks like a thin, relatively featureless line on the scan.
Makes sense. It's just starting to rebuild. What about the proliferative phase, when estrogen is kicking in?
As estrogen levels rise, the endometrium starts to proliferate. It grows thicker. Its characteristic appearance on ultrasound during this phase is described as triple layer or trilaminar.
Triple layer. I've heard that term. What does it look like?
This visual is quite distinct. You see a bright line in the very center representing the collapsed uterine cavity, flanked by 2 slightly darker, thicker layers of developing endometrium. And those dark layers are in turn bordered by 2 brighter lines representing the interface between the endometrium and the uterine muscle, the myometrium.
So bright, dark, bright, kind of.
Sort of, yeah. More like bright, dark, bright, in the middle, dark, bright. But that 3-layered appearance is a hallmark of healthy proliferation under estrogen. The thickness in this phase typically ranges from 7–10 millimeters.
That triple layer is such a classic ultrasound image associated with this phase. And after ovulation, in the luteal phase, when progesterone takes over.
Right. After ovulation, under the influence of progesterone, the endometrium enters the secretory phase, preparing for potential embryo implantation. It becomes more glandular, more complex microscopically. On ultrasound, its appearance changes again, becoming hypoechogenic.
Hyperechogenic, meaning bright.
Yes, it appears uniformly bright, often as bright or even brighter than the surrounding myometrium. The trilaminar appearance disappears, replaced by this single, thick, bright layer. The thickness increases further, typically reaching 8–16 millimeter.
Wow, quite a range there, 8 to 16 millimeter.
It can get quite thick in preparation.
So just to recap the lining, from thin and homogeneous, maybe 1–4 millimeters right after the period, to thicker and distinctly trilaminar, 7–10 millimeters in the proliferative phase, to even thicker and uniformly bright, maybe 8–16 millimeters in the luteal phase.
Yeah.
These predictable changes are absolutely key for evaluating normal uterine function via ultrasound, aren't they?
They really are. If the ET and appearance don't match the patient's LMP and clinical picture, it's a strong indicator that something might be disrupting the normal hormonal cycle, or perhaps there's a structural issue affecting the lining. Understanding these normal cyclical variations is essential.
While the uterus's lining changes, the ovaries are central to orchestrating this process, developing follicles and releasing an egg. Their appearance also changes throughout the cycle, which is discussed on pages 12 and 13. Let's talk ovary size first.
Okay. Page 12 gives us the average size of a normal ovary in a premenopausal woman. Unlike the uterus, which is often measured in 2 main dimensions on a standard view, the ovary is typically measured in 3 dimensions: length, width, and thickness. The source gives averages of 3.5 centimeters long by 2.0 centimeters wide by 1.0 centimeters thick.
So smaller than the uterus, kind of almond-sized.
That's a common description, yes, though the source notes the size can vary.
Why would it vary?
Ovarian size is known to vary depending on the phase of the menstrual cycle because of the developing follicles and the corpus luteum, which take up space, and it also decreases significantly after menopause when hormonal activity ceases. So these average dimensions provide a useful baseline, helping sonographers locate the ovaries and assess if they are significantly enlarged, which could suggest a cyst or other mass.
So roughly 3.5 by 2 by 1 centimeter as a typical benchmark in reproductive years. Page 13 talks about the ovary's location and how it typically looks, its echogenicity.
Right. It describes the typical echogenicity of a normal ovary as moderately echogenic. This means it appears with a medium level of brightness on the ultrasound screen, usually similar to or perhaps slightly darker than the surrounding uterine muscle. It's not bright white or pure black, typically.
Okay, sort of medium gray. And where are they usually found in the pelvis? Is there a typical spot?
They are typically located in the pouch of Douglas, or POD.
The POD?
Yes, also called the cul-de-sac. It's the lowest part of the peritoneal cavity in females, situated between the back of the uterus and the front of the rectum. From the POD, they can sometimes extend a bit higher into the lower abdomen.
So kind of tucked behind the uterus.
Often, yes. The source also describes their position relative to major pelvic blood vessels, anterior and lateral to the iliac vessels. And they are typically found lateral, meaning to the side, of the uterine fundus, the top portion of the uterus.
So sonographers look for them in that cul-de-sac region to the side of the uterus, near those major blood vessels. Those anatomical landmarks must be crucial for finding these relatively small structures, especially if there's bowel gas around.
Absolutely. Knowing these relationships is key for systematically searching for and identifying the ovaries during a scan. The page also reiterates the use of TAS versus TVS for ovarian imaging. It states that TAS is used for patients with thin adipose tissue, meaning less body fat.
Easier to see through.
Potentially, yes, while TVS is used for others.
And why the preference for TVS for many patients when looking at ovaries?
As we touched on, TVS probes use higher frequencies and are placed much closer to the ovaries. This allows for higher resolution imaging, providing a clearer, more detailed view of the ovarian tissue itself and any structures within it, like tiny follicles or the details inside a cyst. This improved detail is often necessary for a thorough evaluation, especially of ovarian structures.
That makes sense. Closer access, higher frequency, better picture.
Speaking of structures within the ovary, the development of follicles and the corpus luteum are central to the cycle and have distinct ultrasound appearances, covered on page 15.
Right. Page 15 details the appearance of follicles and the corpus luteum throughout the cycle. It explains that in the early part of the cycle, developing follicles are first seen on a TVS as groups of small, fluid-filled sacs.
Like little black dots.
Exactly, little anechoic black circles. These are described as 4 to 8 antral follicles, each measuring about 3–5 millimeters in size. Antral follicles are these small follicles visible by ultrasound, each containing an immature egg. You see a collection of them. So you start by seeing a cluster of these tiny black circles within the ovary early on.
Yes. Then, as the cycle progresses towards ovulation, one follicle typically outgrows the others and becomes dominant. Around cycle days 9 to 10, this leading follicle can be identified with a diameter of about 10 millimeters, so 1 centimeter.
Okay, so one starts to pull ahead.
Yes, the source notes it then grows rapidly, maybe 1–2 millimeters per day, reaching 20 to 24 millimeter in size, so 2 to 2.4 centimeters just before ovulation.
That's quite big, relatively speaking. What happens to the others?
The other subordinate, non-dominant follicles in the group usually reach about 10 millimeters and then undergo atresia, meaning they essentially degenerate and shrink away. They don't mature fully.
So one gets big and wins the race, and the others wither away. What happens after ovulation, after the egg is released?
After the dominant follicle ruptures and releases the egg, the source says it collapses. It then transforms into the corpus luteum, or CL, which is the structure that produces progesterone in the second half of the cycle.
And does the corpus luteum look different from the follicle?
Yes, its appearance changes on ultrasound. The source says the content of this structure, which was previously the clear fluid of the follicle, appearing black, may become slightly heterogeneous.
Heterogeneous meaning mixed echoes, not just black.
Right. It's not uniformly black anymore and might have some internal texture or echoes. The wall also thickens as the cells luteinize. This is a process where the granulosa cells enlarge and accumulate lipid, contributing to that progesterone production. And in most cases, the antrum, the internal space, fills with some blood after ovulation.
So it could look like a cyst with a thick wall and maybe some stuff inside.
It can, yeah. It might look like a cyst with thick, maybe slightly irregular or crenated walls, and internal echoes due to the blood clot forming inside. It can look quite complex sometimes. However, the source also notes that occasionally the corpus luteum can form a more homogeneous, hypoechoic, thin-walled structure.
Hypoechoic, meaning dark gray, but not pure black.
Yes, darker than the surrounding ovary, but not necessarily completely black like a simple follicle, so it might look more like a simple fluid-filled cyst in some cases, although the more complex appearance with thicker walls and internal echoes is perhaps more typical.
Is there a size limit for what's considered a normal follicle or corpus luteum? Like, how big can these normal things get?
Yes, and this is a crucial detail for distinguishing these normal physiological structures from potentially pathological ovarian cysts. The source states that the diameter of a normal follicle or corpus luteum does not usually exceed 30 millimeters or 3 centimeters.
Ah, okay. So up to 3 centimeters is generally considered within the normal functional range.
Pretty much. Any cystic structure in the ovary larger than this 30 millimeter threshold immediately raises suspicion for being something other than a normal temporary functional structure and needs closer evaluation.
That 30 millimeter marker is a key takeaway. Then a simple way to start differentiating normal from potentially problematic cystic findings in the ovary.
Absolutely. It's one of the first things assessed when a cystic structure is identified. Size matters here.
We've now covered the normal appearances and cyclical changes of the uterus and ovaries. This establishes our baseline, what we expect to see. The next step in our deep dive is to explore how ultrasound helps us identify when things deviate from this norm, the abnormal findings. Page 17 introduces a list of these pathologies.
Right. Page 17 provides an overview or a list of the range of abnormalities that gynecological ultrasound can help identify. It reinforces the diagnostic power of the tool, showing what kinds of things we might find.
It seems to organize the list by the affected organ uterus first, then ovaries.
Yes. Under uterine abnormalities, it lists fibroid and adenomyosis, which we already got a preview of back on page 2. It also includes conditions in patients with abnormal bleeding, suggesting that ultrasound plays a key role in investigating the causes of bleeding issues, not just diagnosing specific named conditions.
Okay, looking for the why behind the bleeding.
And for the ovaries?
For the ovaries, it lists ovarian cyst, which we know can be physiological or pathological, endometriosis, teratomas.
Keratomas. Those are the ones that could have hair and teeth sometimes. That's right, also known as dermoid cysts. And it lists ovarian cancer. The inclusion of others indicates that this list, while covering common and important conditions, is not exhaustive. There are other, rarer things that might be seen.
So this page acts as a roadmap for the rest of our deep dive into pathology, doesn't it? It promises to show us the specific ultrasound features of these conditions, building on those brief descriptions we got earlier.
Precisely. It signals the transition from understanding the normal state to recognizing the myriad ways pathology can alter the ultrasound appearance of the pelvic organs. We're moving into the abnormal section now.
So following this roadmap, let's start with the uterus and one of the most frequently encountered abnormalities, fibroids. Page 18 simply announces this section, just the title.
Yes, page 18 serves as the title page for this segment, clearly indicating our focus is now on uterine fibroids, also called leiomyomas.
Page 19 gets into the detailed ultrasound appearance of fibroids. How are they described here? What do they look like?
Fibroids are described fundamentally as solid masses located within the body of the uterus, which is the main muscular part. A key characteristic highlighted, consistent with the preview on page 2, is that they are well-defined.
Well-defined again. Clear borders.
Yes. They're often described as encapsulated because they usually have clear, discernible borders that separate them from the surrounding normal uterine muscle, the myometrium. This clear margin is a crucial distinguishing feature, making them look like discrete lumps or balls within the muscle.
Well-defined is the opposite of that diffusely infiltrative description for adenomyosis, isn't it?
Exactly. It points to the focal nature of fibroids compared to conditions like adenomyosis. The source also elaborates on their internal appearance, stating they have variable echogenicity.
Variable, meaning they don't all look the same inside.
Correct. They can be hyperechoic, appearing brighter than the myometrium,
Brighter than the muscle.
or hypoechoic, appearing darker than the myometrium.
Darker than the muscle.
Or sometimes both, having a mixed echogenicity. This variability depends on the composition of the fibroid, whether it's predominantly muscular or has more fibrous tissue, or perhaps has undergone degenerative changes.
So the internal texture isn't always uniform, even though the border is clear. It could be bright, dark, or mixed.
Correct. The internal appearance can differ significantly between fibroids or even within a single large fibroid.
And page 20 specifically discusses these variations, focusing on degenerative changes. What causes these changes?
Well, fibroids, especially larger ones, can sometimes outgrow their blood supply. When that happens, parts of the fibroid tissue don't get enough oxygen, leading to degenerative changes within the tissue.
Okay, so the inside starts to break down a bit.
Sort of, yes. The source explains that when this happens, the ultrasound appearance can become more complex. A degenerating fibroid may show multiple hypoechoic, darker, and hyperechoic, brighter, patchy areas within it.
Ah, so that explains some of the variability in echogenicity mentioned on the previous page. Degeneration causes patchiness.
It certainly contributes. Degeneration introduces areas of differing tissue composition and fluid content. The source specifies that degenerative changes can include areas of necrosis, which is tissue death,
Necrosis, right?
and hemorrhage, which is bleeding within the fibroid. These processes result in varying appearances on ultrasound, ranging from cystic areas, dark, fluid-filled spots representing liquefaction or old blood, to a generally inhomogeneous texture.
Inhomogeneous. So the mass is no longer uniformly solid or textured, but has mixed areas throughout, like it looks messy inside.
Yes, degeneration can make the appearance less straightforward than the classic homogeneous solid mass. It can look quite complex or messy inside, complicating the ultrasound assessment somewhat, making it harder sometimes to be absolutely certain it's just a fibroid without considering other possibilities.
Okay, page 23 introduces another potential change that can happen in fibroids, calcification, like little bits of bone forming.
Essentially, yes. Calcium deposits form within the fibroid tissue. This often happens in older fibroids, particularly in postmenopausal women or in fibroids that have undergone significant degeneration.
And what does that look like on ultrasound? Is it obvious?
It can be quite obvious. The source describes two main patterns for calcification. It can appear as a peripheral ring around the edge of the fibroid.
Like a shell?
Kind of, yeah. Or as a popcorn-type pattern, which likely refers to scattered, irregular clumps of calcification throughout the mass. These areas of calcification appear brightly echogenic on the scan.
Very bright white.
Usually, yes, because calcium strongly reflects sound waves, and crucially, there's something else associated with it.
Shadowing.
Exactly. The source notes that calcification is seen as brightly echogenic with shadowing behind it. As also explained later in the presentation regarding benign ovarian masses, dense structures like calcification block the ultrasound beam entirely. They don't let the sound pass through. This creates a dark area and acoustic shadow extending downwards from the bright spot on the image.
So spotting those bright white areas with distinct dark shadows trailing behind them is a clear sign that there's calcification within the fibroid. That's a very useful visual cue.
It is, and it helps further characterize the fibroid's composition and suggests it's likely been there a while or has degenerated.
Okay, so fibroids. Well-defined, variable echogenicity can degenerate, becoming patchy or cystic inside, and can calcify, showing bright spots with shadows. Now, moving from these well-defined masses, the outline takes us to adenomyosis, which was described early on as diffusely infiltrative. Pages 26, 27, 29, and 30 provide more detail on this condition.
Right. Page 26 begins the discussion on diagnosing adenomyosis with ultrasound, and it immediately states a key challenge. Diagnosis can be difficult because there isn't one single characteristic feature that confirms it definitively.
So it's not like saying if you see X, it's definitely adenomyosis. It's more subtle.
It's often more subtle, yes. The source explains that diagnosis is based on identifying a combination of features. It lists some key indicators to look for. Changes in the echogenicity of the myometrium, the muscle wall.
The texture of the muscle looks wrong.
Yes, it looks abnormal.
Yeah.
Also, thickening of the posterior uterine wall. The back wall is often thicker than the front. And anterior displacement of the endometrial cavity, the lining might look pushed forward because the back wall is so thick. These features, when seen together, collectively suggest the diffuse abnormality within the muscle layer that characterizes adenomyosis.
Okay, it's a constellation of findings. Page 27 provides a more detailed list of features that are suggestive of adenomyosis. Let's unpack those one by one to get a clearer picture of what the sonographer is looking for.
Sure. First on the list is uterine enlargement not explained by fibroid.
Meaning the uterus is big, but not because of a discrete lump.
Exactly. The uterus is larger than normal, often described as bulky, but there are no distinct fibroid masses accounting for that increased size. The enlargement is due to a general thickening and, well, bulkiness of the muscle wall itself.
Okay, so the whole uterus feels bulky, but not from specific lumps. What's next?
Asymmetrical thickening of anterior, or usually posterior, uterine walls. One part of the uterine wall, most commonly the posterior wall, is significantly thicker than the other parts. This asymmetry is quite common.
This asymmetry contributes to the overall bulky feeling and maybe changes the shape.
It does. It also makes the uterus lose its typical pear shape and become more globular or rounded, which is another feature often seen in adenomyosis, mentioned later in the source on page 29.
Globular shape, okay. What else is on the list on page 27?
And another feature listed is lack of contour or abnormality effect despite enlarged bulky uterus. This is a bit nuanced. Unlike large fibroids that can dramatically distort the external shape of the uterus, making it look lumpy on the outside, with adenomyosis, the uterus can be enlarged and bulky, but its external contour might remain relatively smooth. The abnormality is more internal, affecting the texture of the muscle, rather than causing big external bumps.
So the problem is more inside the wall than bulging outwards.
Often, yes, that's the idea. Then we have heterogeneous and poorly circumscribed areas in the myometrium.
Heterogeneous, patchy again, and poorly circumscribed, fuzzy borders.
Exactly. This describes the patchy appearance we mentioned earlier. The muscle layer looks non-uniform, and the abnormal areas, which might be brighter or darker than normal muscle, lack clear, distinct borders. They kind of blend into the surrounding muscle. This poorly circumscribed nature is a key contrast to the well-defined fibroids.
That lack of clear borders really seems important for distinguishing it from fibroids.
It is. It reflects the infiltrative nature of the condition. The abnormality sort of seeps into the surrounding normal tissue rather than being neatly separated like a fibroid usually is.
Okay. Any other features on this list?
Yes, along similar lines, there are poorly defined focal areas of hypoechoic texture within the myometrium. These are localized spots or streaks within the muscle layer that are abnormally bright or dark, again, without sharp boundaries, just more evidence of that patchy, non-uniform muscle texture.
And the small cystic areas, that sounds distinctive.
It is. A very characteristic finding mentioned is anechoic cysts or lacunae within the myometrium.
Anechoic means black, right? Like fluid. And lacunae means little gaps.
Correct. These are small, black, fluid-filled spaces or tiny cyst-like structures seen scattered within the thickened muscle wall. They're not in the lining, but in the muscle itself. These are thought to represent tiny pockets of old blood or dilated endometrial glands that have migrated into the muscle.
So seeing these tiny black spots scattered within a bulky, patchy muscle layer is a strong sign suggesting adenomyosis.
Yes, myometrial cysts or lacunae are considered a highly suggestive feature, one of the more specific signs to look for.
This detailed list paints a much clearer picture of what that diffusely infiltrative, inhomogeneous appearance actually looks like on the scan. It's not just one thing, but several potential clues.
It breaks down the components of that overall description, and page 29 reinforces this overall picture. It describes the typical presentation as a large or bulky uterus with a diffusely infiltrative, inhomogeneous appearance of the myometrium. It pulls those features together.
And it mentions a specific type of shadowing associated with it, not the clean shadow of calcification.
No, it's different. It notes the accompanying finding of dirty, streaky shadowing posteriorly. This is thought to be caused by the scattering and absorption of sound waves, by the myriad of small interfaces within the abnormal muscle, the tiny cysts, the fibrous tissue, the areas of muscle thickening. It creates a less distinct, more generalized or streaky area of reduced signal intensity behind the affected area, not a sharp black shadow.
So a messier, less defined shadow than with calcification.
Correct. Page 29 also points out the globular shape of the uterus, often seen in these cases, a consequence of the overall thickening. And it notes that the endometrium, the lining itself, can sometimes be almost obscured or difficult to see clearly.
Why would the lining be hard to see?
Because the junction between the endometrium and the myometrium, which is usually clear, becomes indistinct due to the adenomyosis infiltrating right up to or even into that boundary zone. The abnormal muscle sort of blurs the edge of the lining.
That makes sense if the problem is spread throughout the muscle. Page 30 then connects these visual findings back to the underlying cause. Why does adenomyosis look this way? What's actually happening in the tissue?
Right. This page provides the histological basis, the microscopic reason for the ultrasound appearances. It explains the origin of the cystic areas within the myometrium. These are likely dilated endometrial glands or small areas of hemorrhage that are present because endometrial tissue, glands and stroma, the tissue that normally lines the uterus, has migrated into the muscle wall where it shouldn't be.
Ah, so the little black spots, lacunae, are directly related to that misplaced endometrial tissue growing inside the muscle.
Yes, that's the underlying pathology. Adenomyosis is essentially endometriosis within the uterine muscle wall. The page then details what causes the different echogenic appearances within the muscle.
The bright and dark patches.
Yes. The hyperechoic brighter areas, or streaks, are thought to be caused by the islands of endometrial tissue itself that have migrated into the myometrium. This lining tissue looks different from muscle tissue on ultrasound.
So bright spots are the misplaced lining tissue.
That's believed to be a major component. And the hypoechoic, darker areas are thought to result from hyperplasia, an increase in the number of cells of the myometrial smooth muscle around the ectopic endometrial tissue. The muscle layer thickens and reacts to the presence of the invading endometrial glands and stroma.
So the muscle itself grows thicker in reaction, causing darker areas.
Yeah.
That explains the muscle thickening and the patchy dark spots within the wall.
Exactly. Page 30 provides that crucial link between the microscopic pathology endometrial tissue growing in the wrong place, ectopic endometrium, and the muscle reacting to it, hyperplasia, and the macroscopic ultrasound appearance we see. The bulkiness, the inhomogeneity, the cysts, the shadowing.
Okay, so to summarize adenomyosis, it's often a bulky, maybe globular uterus. The muscle wall looks patchy, inhomogeneous, with poorly defined borders between normal and abnormal areas. You might see asymmetric thickening, especially the back wall. Key signs are those tiny black cysts or lacunae within the muscle, and maybe some streaky shadowing behind it. It's all caused by endometrial tissue invading the muscle wall. That's much clearer now.
That's a good summary of the key features described.
Now, ultrasound is also absolutely critical in evaluating abnormal bleeding, which is a very common reason for needing a scan. Pages 31, 32, and 33 focus on bleeding disorders. Let's start with fertile age women on page 31.
Okay. Page 31 focuses on bleeding disorders in women of reproductive age. It states that the most common causes in this group are functional bleeding disorders of hormonal origin.
Functional meaning no physical problem found, just hormones out of whack.
Often, yes. It means the bleeding is related to imbalances in the hormonal control of the menstrual cycle, rather than a specific structural problem like a polyp or fibroid that you can point to on the scan. But, and this is a vital point the source makes about interpreting the ultrasound findings in this context,
What's the catch?
it makes it very clear. A deviation from the normal structure or thickness of the endometrium for that specific phase of the menstrual cycle, which we discuss based on pages 10 and 11, is not sufficient on its own to diagnose a functional bleeding disorder.
So just because the lining looks maybe a bit thick or thin for the day of the cycle, you can't automatically say, oh, it's just hormonal bleeding.
Correct. You can't look solely at the ultrasound and make that diagnosis. This underscores the point we made right at the beginning about ultrasound being a tool used alongside clinical information.
The patient's symptoms and history are key.
Absolutely. The patient's history of bleeding patterns is essential for interpreting any endometrial findings. However, the page then provides a key measurement threshold to watch out for in fertile-aged women who do have abnormal bleeding. An endometrial thickness, ET, of more than 18 millimeter suggests endometrial disease.
18 millimeters. That sounds quite thick given the normal ranges we discussed, up to 16 millimeters usually.
It is quite thick for a reproductive age woman. So if the lining is thicker than 18 millimeters in a fertile woman who is experiencing abnormal bleeding, that's considered a red flag. It suggests there might be an underlying issue within the endometrium itself that needs further investigation.
So 18 millimeter ET plus abnormal bleeding in a fertile woman means you should look closer, maybe for polyps or hyperplasia, not just assume it's hormonal.
Yes. While not definitively diagnostic of what the disease is, that degree of thickness is abnormal in the context of bleeding and warrants further investigation beyond just assuming it's hormonal. It raises the suspicion for an organic cause.
Okay. Now, page 32 seems to repeat the information from page 31. Is there anything new there?
It essentially does repeat the same points. It reinforces that functional bleeding is common in fertile women, that ultrasound findings alone aren't enough for diagnosis without clinical context, and crucially, that an endometrial thickness greater than 18 millimeters suggests endometrial disease. The repetition likely serves to emphasize the significance of that 18 millimeter threshold in this specific population group.
Got it. 18 millimeter ET plus bleeding in a fertile woman. Investigate the endometrium further. Now, let's turn to a much more concerning clinical scenario. Postmenopausal bleeding disorders, covered on page 33.
Right. This page deals with a critical situation. The source highlights the importance of postmenopausal bleeding by stating quite starkly that it is a sign of endometrial cancer until otherwise proven.
Wow, that's a very strong statement.
It is. It reflects a fundamental principle in gynecology and emphasizes the urgent need for evaluation whenever a woman experiences bleeding after menopause. It has to be taken very seriously.
So what are the ultrasound findings or thresholds that are relevant in this context? Are they different from fertile women?
Yes, the thresholds are significantly different and lower, reflecting the fact that the endometrium should normally be thin and inactive, or atrophic, after menopause due to lack of estrogen. The source states that an endometrial thickness of 10 millimeters in a postmenopausal patient with bleeding strongly suggests endometrial cancer.
10 millimeters. That's much lower than the 18 millimeter for fertile women.
Precisely. Because the expected normal thickness after menopause is very low, typically less than 5 millimeter, any significant thickening, defined here as greater than 10 millimeters in the presence of bleeding, is highly suspicious for malignancy.
Okay, 10 millimeters is very suspicious in this group. What about if it's thin?
The source also provides a reassuring threshold. It notes that endometrial cancer is extremely rarely seen when the endometrium is 5 millimeters thick in a postmenopausal patient.
Less than 5 millimeters is good news then.
Generally, yes. If a postmenopausal woman has bleeding, but the ultrasound shows a very thin endometrial lining, less than 5 millimeters, the risk of cancer being the cause is very low based on the scan findings. It provides a high degree of confidence.
But is that the end of the story if it's thin?
No, and this is a vital point reiterated by the source. A histological sample of the endometrium, that tissue sample or biopsy, is always needed in cases of postmenopausal bleeding, regardless of the ultrasound findings.
Always, even if the lining is thin, like less than 5 millimeter.
Yes. Even with a thin endometrium, 5 millimeter, the symptom of bleeding itself mandates tissue sampling to definitively rule out malignancy. There are rare cancers that can occur even with a thin lining, or the bleeding could be from a non-cancerous cause like atrophy or a small polyp, but you have to rule out the worst-case scenario. Ultrasound helps risk stratify and guide the investigation. Low risk 5 millimeter, high suspicion 10 millimeter. But histology provides the definitive diagnosis.
So ultrasound provides crucial information for risk assessment, but the clinical symptom of postmenopausal bleeding is serious enough that a tissue sample is always required for confirmation. You can't rely on ultrasound alone to rule out cancer in this setting.
Exactly. Clinical presentation and histological evaluation go hand in hand here. It's a safety net.
While we're on the topic of endometrial thickness and bleeding, let's look at a specific structural cause that ultrasound can identify within the lining. Endometrial polyps, discussed on page 34. What do they look like?
Page 34 describes the typical ultrasound appearance of an endometrial polyp. It's characterized as an ectodense, well-defined round mass located in the uterine cavity.
Ectodense, meaning it appears brighter than the surrounding endometrium.
Yes, usually brighter or at least clearly visible as a distinct structure within the cavity. It's described as well-defined, distinguishing it from diffuse thickening or infiltrative processes, and often round or oval in shape, projecting into the uterine space.
Okay, a bright, distinct lump inside the cavity. When is it easiest to see?
The source notes it's often best visualized during the proliferative phase of the menstrual cycle.
When the lining has that trilaminar appearance.
Exactly. In this phase, the polyp, being ectodense and well-defined, tends to stand out more clearly against the relatively less echogenic, darker layers of the developing proliferative endometrium within the cavity. It provides better contrast.
It's easier to spot against that specific background. Makes sense. Anything else about its appearance?
Yes, the source also mentions that a cystic structure can occasionally be seen within the polyp itself, a small fluid-filled area within the otherwise solid-appearing mass.
And is there a technique that really helps visualize polyps if you suspect one but can't see it clearly?
Absolutely. The source states it can be imaged even better if liquid is present in the uterine cavity or if fluid is introduced with a catheter. This is the principle behind saline infusion sonography, SIS, or sonohysterography, sometimes called hydrosonography.
Putting water in.
Sterile saline, yeah. By gently injecting sterile saline into the uterine cavity through a thin catheter, you distend the space. The fluid surrounds the polyp, outlining it beautifully and making it much easier to see, measure, and evaluate compared to when the cavity walls are collapsed together. It really highlights any intracavitary structures.
That sounds like a very useful technique for confirming the presence and location of polyps or other things inside the cavity, like submucosal fibroids.
It is extremely useful for evaluating the endometrium and uterine cavity.
Okay. Moving outside the uterus now, let's explore findings related to the ovaries, starting with the very common finding of an ovarian cyst. Page 35 is just the title.
Yes, page 35 is simply the title page for ovarian cyst, indicating our focus is now on cystic structures originating from the ovary.
Page 36 dives into the evaluation of ovarian cysts, starting with a fundamental challenge, it seems.
Yes, the key challenge highlighted right away is distinguishing between physiological and pathological cysts. As we learned when discussing normal ovarian anatomy, page 15, normal ovarian function involves the formation of cystic structures, the developing follicle that grows to maybe 24 millimeters, and then the corpus luteum that can reach up to 30 millimeters.
Right, those are normal cysts that are part of the cycle.
Exactly. So seeing a cyst in the ovary is not automatically abnormal or worrying. It could just be a functional cyst related to the menstrual cycle.
That's a really important distinction. How does the source help us start that differentiation? Is size a factor?
Yes, it provides a general size threshold as a starting point. It says cysts less than 5 centimeters, or 50 millimeter, are often physiological and likely benign.
Less than 5 centimeters, okay.
This implies that many smaller cysts fall within the size range of exaggerated but still temporary functional structures, like a large dominant follicle that didn't rupture or a simple corpus luteum cyst. The implication is that many of these smaller ones will resolve on their own without intervention.
So under 5 centimeters is often reassuring, suggesting it might just go away by itself.
It's a starting point for classifying potentially low-risk cysts, yes, suggesting they might just be part of the normal cycle or a simple benign cyst that will resolve. The source then addresses the next critical distinction, benign versus malignant ovarian cysts.
Okay, non-cancerous versus cancerous.
Right, and it provides a very reassuring statistic stating that 95% of ovarian cysts are benign. The vast majority are not cancerous.
95%. That's high. That's good news.
It is good news. However, identifying the small percentage, the 5% that are potentially malignant, is obviously paramount. Early detection is key for ovarian cancer.
So how do you tell if a cyst might be in that worrisome 5%? Or at least not just a simple physiological one? What's a key indicator mentioned?
Persistence. The source highlights that persistence of a cyst over more than 3 menstrual cycles suggests it may not be a simple physiological cyst that will disappear on its own, and therefore warrants further investigation.
More than 3 cycles. So if it's still there after about 3 months?
Essentially, yes. Physiological cysts, like follicles or corpus luteum cysts, typically resolve within 1 to 2 cycles. If a cystic structure hangs around longer than that, it's less likely to be purely functional.
So size under 5 centimeters is often okay initially. But if it's still there after 3 cycles or so, it needs a closer look, regardless of size.
Exactly. Persistence is a key factor prompting further evaluation, and that closer look involves carefully evaluating the internal characteristics of the cyst, which brings us to established criteria for distinguishing benign from malignant, presented on page 37.
Page 37 presents the 10 simple rules for identifying benign and malignant ovarian tumors. These sound like standardized criteria used by experts to try and categorize these things.
They are indeed. These rules, developed by the International Ovarian Tumor Analysis (IOTA) group, provide a standardized, evidence-based approach to evaluating ovarian masses using specific ultrasound features to predict the likelihood of malignancy. The system includes 5 features that suggest malignancy, called the M rules, and 5 features that suggest benignity, the B rules.
Okay, 5 signs pointing towards malignancy, M rules, and 5 pointing towards benign, B rules. Let's go through the 5 malignant M rules first. What's M1?
M1 is irregular solid tumor. This describes a mass that is primarily solid tissue, not just fluid-filled, and importantly, it has irregular margins or an irregular internal structure. That irregularity in a solid mass is often associated with uncontrolled, disorganized growth, which can be a feature of cancer.
So solid and messy looking is bad.
M2.
M2 is presence of ascites.
We mentioned ascites earlier, fluid in the abdomen. Why is that linked to malignancy? Ascites, the accumulation of excess free fluid in the abdominal cavity when seen in conjunction with an ovarian mass, is a significant red flag. It can be a sign of advanced ovarian cancer where malignant cells may have spread to the lining of the abdomen, the peritoneum, causing irritation and fluid buildup.
Okay, ascites is a worrying sign, M3.
M3 is at least 4 papillary structures.
Papillary structures, so what are those exactly? Little growths.
Yes, they're described as finger-like or cauliflower-like projections that grow from the inner wall of the cyst, projecting into the internal space, the lumen. While 1 or 2 tiny smooth papillae might sometimes be seen in benign cysts, the presence of 4 or more distinct papillary projections is considered highly suspicious for malignancy. They represent areas of active growth on the cyst wall.
4 or more papillae.
Yep.
Got it. M4. This one sounds complex.
M4 is irregular, multilocular solid tumor with largest diameter 100 millimeters. Let's break that down. Multilocular means it has multiple compartments or cysts separated by internal walls called septations. It also has significant solid components, meaning areas of tissue that are not fluid. When such a complex mass with multiple compartments and solid bits is also irregular in shape or internal structure, and it's large, 100 millimeter, which is 10 centimeters or more in diameter, that combination is very concerning for cancer.
So big, over 10 centimeters, complex, multiple compartments and solid parts, and irregular is a really bad combination of features.
Precisely. Each element adds to the suspicion. Finally, M5. M5 is very strong blood flow, often referred to as color score 4. This is assessed using Doppler ultrasound, which detects blood flow within blood vessels inside the mass.
Why is blood flow important?
Malignant tumors often require a rich blood supply to sustain their rapid growth and spread. They induce the formation of new blood vessels, angiogenesis. A high color score, typically score 4, represents very strong. Abundant blood flow detected throughout the mass by the Doppler indicates significant vascularity. This high vascularity is a feature often seen in malignant cancers.
Okay, so the 5 malignant signs, M rules, are irregular solid tumor, ascites, 4 or more papillae, a large 10 centimeter irregular multilocular sulfur, and very strong internal blood flow. Now, what about the 5 benign B rolls? What features suggest it's likely not cancer?
These are the features that are reassuring. B1 is unilocular.
Unilocular means
Yeah.
just one single compartment.
Exactly. This describes a simple cyst with a single compartment, thin walls, and no solid bits or papillae. Simple cysts like this are overwhelmingly benign.
Okay, simple is good. B2.
B2 is presence of solid components, where the largest solid component has the largest diameter, 7 millimeter.
So it's okay to have some solid parts as long as they are very small, less than 7 millimeters.
Yes. This rule acknowledges that tiny solid-looking areas can sometimes be seen, like a small blood clot or debris. But if the largest solid bit is very small, less than 7 millimeters, it's considered a benign feature and less concerning than larger or more irregular solid areas, like an M1 or M4.
Okay, tiny solid bits are usually fine. B3.
B3 is presence of acoustic shadows.
We saw this with fibroid calcification.
Yeah.
How does it apply to ovaries?
Yes, same principle. In ovarian masses, acoustic shadowing suggests the presence of very dense material within the mass that blocks the ultrasound beam, creating that dark shadow behind it. This is a characteristic finding of certain benign ovarian tumors, particularly dermoid cysts or mature cystic teratomas, which we mentioned earlier.
The ones with hair and teeth.
Right. Dermoids can contain dense tissues like bone, teeth, fat, or hair, all of which can cause shadowing. So seeing shadowing often points towards a benign dermoid cyst.
So shadowing in an ovarian cyst, unlike in some other contexts, often points towards a specific benign diagnosis here.
It can be a strong indicator of dense components typically found in dermoids, thus suggesting benignity in this context. B4. B4 is smooth multilocular tumor with largest diameter 100 millimeter.
This sounds a bit like M4. Irregular multilocular solid 100 millimeter, but this one is benign. What's the difference?
Yes, the key differences are smooth walls and being under 100 millimeters, 10 centimeters. A multilocular cyst, one with multiple compartments, can certainly be benign if the internal walls, the septa, are smooth and thin, the overall external contour of the mass is smooth, and it's not excessively large, under 10 centimeters. It's the combination of irregularity, significant solid components, and large size that pushes a multilocular mass towards the malignant category, M4. Smooth and smaller is reassuring.
Smoothness is key. Okay, and finally B5.
B5 is no blood flow, often described as color score 1.
The opposite of M5, strong flow.
Exactly. Assessed by Doppler ultrasound, a color score of 1 means no significant blood flow is detected within the mass or its wall septa. The absence of significant internal vascularity is a reassuring sign, suggesting the mass is not actively growing rapidly or doesn't have the extensive blood vessel network typical of many cancers.
So these 10 simple rules give sonographers and clinicians a structured framework looking at size, internal structure, solid versus cystic compartments, papillae, the presence of ascites, acoustic shadowing, and blood flow to assess the likelihood that an ovarian mass is benign or malignant. It's a way to standardize interpretation and guide management decisions, isn't it?
Exactly. These rules are designed to be used in combination. For example, if a mass has several M rules present and no B rules, it's classified as highly suspicious for malignancy. Conversely, if it has one or more B rules and no M rules, it's likely benign. Cases that have both M and B features or don't fit neatly are considered indeterminate and may require further investigation or expert opinion. It's a very practical system.
Very helpful. Finally, our sources cover the role of ultrasound in identifying and managing infections in the pelvic area. Page 48 focuses on pelvic infection. What does it cover specifically?
Page 48 specifically discusses a serious complication of pelvic inflammatory disease, PID, which is tubo-ovarian abscess, often abbreviated as TOA. This is where the infection involves both the fallopian tube and the ovary, leading to the formation of a collection of pus and abscess involving these structures.
That sounds serious. What does a TOA typically look like on ultrasound? Can you see the pus?
You can see the effects of it. The source describes a TOA as a multilocular, thick-walled mass that contains echo-dense fluid collections.
Okay, let's break that down. Multilocular, multiple compartments again.
Yes, like some complex cysts, it often has multiple compartments or pockets, reflecting the complex inflammatory process involving the tube and ovary sticking together. But importantly, the walls separating these compartments and the outer wall of the mass are typically thick and may appear irregular, suggesting inflammation and infection.
Thick walls, okay. And the fluid inside isn't just black.
Right. The fluid inside is usually not simply black, anechoic, like clear fluid in a simple cyst. It typically appears echodense, meaning it contains internal echoes, it looks murky, grayish, or might even have fluid debris levels. This appearance suggests the presence of debris, pus, or possibly blood within the infected fluid collection.
So a messy, complex, compartmentalized mass with thick borders and murky fluid inside sounds like it would look quite angry on the scan.
That's a good way to put it. It often looks like an inflamed, complex collection. The source then discusses what happens as the infection subsides with treatment, like antibiotics. The infectious complex, the TOA, may either disappear completely as the infection resolves.
That's the best outcome.
Yes. Or it can transition into something called a sac-to-salpinx.
Sac-to-salpinx, what is that?
A sac-to-salpinx, often called a hydrosalpinx if the fluid is clear, is essentially a damaged fallopian tube. The infection causes the end of the tube, the fimbrial end near the ovary, to become blocked and scarred shut. Fluid then builds up within the tube, causing it to dilate and become a fluid-filled sac.
So the tube itself becomes a blocked, fluid-filled structure.
Exactly. On ultrasound, it appears as an elongated, often folded or sausage-shaped multilocular mass, reflecting the shape of the dilated, fluid-filled fallopian tube.
Elongated and multilocular. Okay. And the source mentions a risk associated with having a sac-to-salpinx.
Yes, it notes that a sac-to-salpinx, especially if it's large and mobile, can sometimes undergo torsion. Torsion means twisting. The fluid-filled tube twists on its supporting structures.
Cutting off its blood supply. That sounds painful.
It is. Torsion of a sac-to-salpinx is a surgical emergency, causing severe acute pelvic pain.
How do you identify torsion of a sac-to-salpinx using ultrasound? Is it different from ovarian torsion?
Yes, the distinction is important. The source states that torsion of a sac-to-salpinx is usually identifiable from different scanning angles, and crucially, the ovary on that side will typically be seen as a separate structure from the twisted mass, sac-to-salpinx.
Ah, so you see the ovary looking maybe normal next to this twisted, fluid-filled tube.
Yeah. Yes. This is a key point of distinction from ovarian torsion, where the ovary itself is twisted, usually appears enlarged and abnormal, often with altered blood flow, and the tube might be twisted along with it. Seeing the ovary clearly separate from the twisted tubal structure helps diagnose isolated tubal torsion involving a sac-to-salpinx.
So the visual separation of the ovary from the elongated, fluid-filled mass is the key sign for tube torsion in this context.
Yes, along with the clinical picture of acute pain, that's a primary finding. The source also mentions some smaller details that might be seen within the walls of a sac-to-salpinx itself. Small pseudopapillae, typically only 1 to 2 millimeters in size, may be seen projecting from the inner walls.
Pseudopapillae, like fake papillae.
Sort of. They are tiny inflammatory projections or folds of the tubal lining, much smaller and less concerning than the significant papillary structures. Remember, O4 suggesting malignancy in ovarian masses M3. It's important not to mistake these tiny folds for cancerous growths.
That's a really important distinction. Small, regular bumps in a tube might just be post-inflammatory changes, not cancer.
Exactly.
Let's try and consolidate some of the absolute top takeaways from all this information. What are the key messages?
Okay, first, and maybe most importantly, ultrasound is a vital, non-invasive tool in gynecology, but it must always be interpreted within the full clinical context, including patient history, symptoms, and especially the last menstrual period, LMP. It doesn't replace clinical judgment.
Right. Context is king. Second, normal uterus and ovaries have specific average size ranges to keep in mind, like uterus roughly 7.58 centimeters long, ovaries around 3.5 centimeters long in reproductive years, and characteristic appearances on the scan.
Third, the endometrium, the uterine lining, shows predictable cyclical changes in both thickness and appearance throughout the menstrual cycle. Thin and homogeneous, 1-4 millimeters just after menses.
Then thicker and trilameter, 7-10 millimeters in the proliferative phase.
And then thickest and uniformly hyperechogenic or bright, 8-16 millimeter in the luteal phase. Knowing this pattern is crucial.
Fourth, normal functional structures in the ovary, like follicles and the corpus luteum, are cystic but typically don't exceed 30 millimeters, 3 centimeters in diameter. Size helps differentiate normal from potentially pathological cysts.
Fifth, ultrasound is great at identifying common pathologies. Fibroids typically appear as well-defined, often encapsulated masses within the uterine muscle with variable internal echogenicity, bright, dark, or mixed, and they can sometimes show calcification, bright spots with shadows, or degenerative changes, patchy cystic areas.
Sixth, adenomyosis looks very different. It's characterized by a diffusely infiltrative, inhomogeneous appearance of the myometrium, meaning the muscle wall looks patchy and has indistinct borders. Often there's asymmetric thickening, especially at the back wall, tiny black cysts called lacunae within the muscle, and maybe streaky shadowing, resulting in an overall bulky or globular uterus.
Seventh, endometrial thickness, ET, is a key measurement when investigating abnormal bleeding. In fertile women, an ET over 18 millimeters suggests underlying endometrial disease and needs further evaluation.
Eighth, the rules change after menopause. Postmenopausal bleeding always requires investigation, usually including a biopsy. On ultrasound, an ET 10 millimeters is highly suspicious for endometrial cancer, while an ET 5 millimeter makes cancer very unlikely, but doesn't eliminate the need for biopsy if bleeding is present.
Ninth, endometrial polyps can cause bleeding and are typically seen on ultrasound as eccredents, bright, well-defined, round or oval masses within the uterine cavity. They are often best visualized during the proliferative phase or with saline infusion sonography.
10th, for evaluating ovarian cysts, the IOTA 10 simple rules help assess the risk of malignancy based on specific features. Benign signs include being unilocular, having only tiny solid parts, 7 millimeter, acoustic shadowing, suggesting dermoid, being a smooth multilocular fist under 10 centimeters, and having no internal blood flow.
And inversely, malignant signs include being an irregular solid tumor, the presence of a cysts, having 4 or more papillary projections, being a large 10-centimeter irregular multilocular solid tumor, and showing very strong internal blood flow.
And finally, pelvic infections like tubo-ovarian abscesses, TOA, appear as complex, multilocular, thick-walled masses containing echo-dense, murky fluid. Resolution can lead to a sactosulpinx, a blocked, fluid-filled tube, which itself carries a risk of torsion, identifiable on ultrasound if the ovary is seen separately from the twisted tube.
That covers the main highlights across the topics.
That's a really solid summary of the key points covered in our source material. Now, to help lock that information in, let's see how well you were listening with a few multiple-choice questions drawn directly from the source material we've just discussed. Ready?
Let's do it. Here are 10 questions for you to test your understanding.
Okay. Question number 1. What is the typical thickness of the endometrium during the proliferative phase of the menstrual cycle? Is it A, 1 to 4 millimeter, B, 7 to 10 millimeters, C, 8 to 16 millimeter, D, 18 millimeter?
Okay, proliferative phase, that's the middle part, driven by estrogen with the trilaminar look. The source on page 11 gave the thickness range for this phase as 7-10 millimeters. So the answer is B, 7-10 millimeter.
Correct. Number 2, which ultrasound appearance is characteristic of the endometrium right after menses? A, triple layer trilaminar, B, hyperechogenic, C, homogeneous,
D.
empty.
Right after menses, the lining is at its thinnest. Page 11 described this appearance as homogeneous and typically 1-4 millimeter thick, so the answer is C, homogeneous.
Spot on. Number 3, a diffusely infiltrative, inhomogeneous appearance of the myometrium is characteristic of which condition? A, uterine fibroid, B, endometrial polyp, C, ovarian cyst, adenomyosis.
That description, diffusely infiltrative, inhomogeneous, was used repeatedly for adenomyosis, contrasting it with well-defined fibroids or polyps. Pages 26, 27, and 29 all pointed to this. The answer is D, adenomyosis.
Excellent. Number 4, in a postmenopausal patient with bleeding, an endometrial thickness of 10 millimeters strongly suggests which condition? A, physiological atrophy, B, endometrial polyp, C, endometrial cancer, D, adenomyosis.
This was a critical point from page 33 regarding postmenopausal bleeding. An endometrial thickness greater than 10 millimeters in that context is highly suspicious and strongly suggests endometrial cancer requiring biopsy. So the answer is C, endometrial cancer.
Perfect. Number 5, according to the sources, approximately what percentage of ovarian cysts are benign? A, 50%, B, 75%, C, 95%, D.
Page 36 gave us that reassuring statistic when discussing the benign versus malignant distinction for ovarian cysts. It mentioned that 95% are benign. The answer is C, 95%.
Got it. Number 6, which feature is listed as suggestive of a malignant ovarian tumor according to the 10 simple rules? A, unilocular structure, B, presence of ascites, C, presence of acoustic shadows, D, smooth multilocular tumor 100 millimeters.
We need to recall the M rules for malignancy from page 37. M2 is the presence of ascites. The other options listed here, unilocular, acoustic shadows, smooth, multilocular 100 millimeters, were all B rules, suggesting benignity. So the answer is B, presence of ascites.
Right again. Number 7, a well-defined round eccodense mass in the uterine cavity, best visualized during the proliferative phase, describes which condition? A, uterine fibroid, usually in muscle, not cavity unless submucosal. B, adenomyosis, diffuse in muscle. C, endometrial polyp. D, tubo-ovarian abscess, complex mass in adnexa.
That description, ecodens, bright, well-defined, round, in the cavity, best seen in proliferative phase, matches the description of an endometrial polyp given on page 34. The answer is C, endometrial polyp.
Correct. Number 8. What is the normal size limit for a follicle or corpus luteum according to the sources?
Yeah.
A, 10 millimeters, B, 24 millimeters size before ovulation but not the limit, C, 30 millimeter, D, 50 millimeters or 5 centimeters, often used as initial cutoff for simple cysts, not functional ones.
Page 15 discussed the growth of follicles and the corpus luteum. It explicitly stated that the diameter of a normal follicle or corpus luteum does not usually exceed 30 millimeters, 3 centimeters. Above this raises suspicion. The answer is C, 30 millimeters.
Exactly. Number 9. Areas of necrosis and hemorrhage causing varying appearances from cystic to inhomogeneous can occur in which uterine abnormality. A, endometrial polyp. B, adenomyosis. Uterine fibroid, degenerative changes, AD, retained products of conception, not discussed but different context.
Page 20 specifically described how degenerative changes in uterine fibroids due to outgrowing blood supply can include necrosis and hemorrhage, leading to these complex, varied appearances, sometimes cystic or inhomogeneous. The answer is C, uterine fibroid, degenerative changes.
Yes, and the last one, number 10. A multilocular, thick-walled mass containing echo-dense fluid collection seen in the pelvis is characteristic of what?
Yeah.
Endometrial polyp in cavity, usually solid. B, ovarian cyst, benign ones, usually thin-walled, clear fluid. C, sac to salpinx, elongated tube, maybe thin walls and less acute. D, tubo-ovarian abscess.
That exact description, multilocular, thick-walled, with echo-dense, murky fluid, was given on page 48 as the characteristic appearance of a tubo-ovarian abscess resulting from pelvic infection. The answer is D, tubo-ovarian abscess.
Fantastic. How did you do on the quiz at home?
Hopefully running through those questions helped reinforce the key distinguishing features and thresholds we discussed from the source material. It really tests if you picked up on those specific visual cues and numbers.
Absolutely. These questions highlight the importance of recognizing specific ultrasound appearances and measurements to differentiate between normal physiology and various pathologies. It's about pattern recognition, but also knowing the rules and guidelines.
As we wrap up this deep dive into basic gynecological ultrasound, consider this provocative thought. How truly remarkable is it that sound waves, vibrations we cannot see with our eyes, can be used to create detailed visual maps of the delicate and complex anatomy hidden deep within the body? It's like echolocation, but for medicine. It really is an ingenious application of physics.
What are the limits of what we can currently see and understand with this technology? And perhaps more excitingly, what future advancements might allow us to see even more? Maybe resolving smaller details, understanding tissue characteristics better, perhaps even visualizing things at a near cellular level non-invasively. What could that unlock about the body's hidden processes, potentials, and the very earliest signs of disease?
It's a powerful reminder of how physics and biology intersect to provide essential diagnostic capabilities. And the technology is constantly evolving, better resolution, new techniques like elastography, contrast agents. It keeps pushing the boundaries of what we can non-invasively understand about human health. The future is certainly exciting.
Absolutely. Well, thank you for joining us on this exploration of basic gynecological ultrasound. We trust this deep dive into the source material has illuminated the core concepts and diagnostic power of this essential tool, giving you a clearer picture of how it's used to evaluate female pelvic health.
Hopefully it's been informative. Keep asking questions and keep exploring. The journey of understanding the human body is a deep and fascinating one, and tools like ultrasound are key parts of that journey.
And remember, if you're keen to continue your learning journey in this or other areas, do explore the extensive offerings at London Heartbeat's Z Academy UK. And don't forget to subscribe to their social channels on Facebook, Instagram, and YouTube to stay updated with their latest content and educational opportunities. Until our next deep dive, keep digging for knowledge.